Good afternoon. My name is Ty Johnson. I am the Chief Operating Officer for both IDSA and IDSA Foundation. On behalf of the entire leadership team at IDSA, we are thrilled you made time today to join us for the John Bartlett webinar series entitled Preparing for the upcoming 2024-2025 respiratory season. This webinar today is supported by Moderna Pharmaceuticals. Before we get started, there are a few housekeeping items I'd like to go over. First of all, the webinar is indeed recorded. The recording will be available on the IDSA Foundation website or YouTube channel, as soon as the webinar is over. All attendee mics will be muted, and please use the Q&A Zoom feature when we get to the Q&A section. And we will try to follow up with an email response to all unanswered questions, as we may not get to all of them. I will now welcome Dr. Shweta Anjan to the presentation.
Good afternoon, everyone. I'm Shweta Anjan, a transplant infectious disease physician at the University of Miami and Jackson Memorial Hospital. I'm also the program director for the Transplant ID Fellowship program here. I'm part of the Rising Leaders group of class of 2022 and part of the newly formed IDSA Leadership Institute Alumni Advisory Panel. So the reason I bring this up is I highly recommend the Rising Leaders program for early career physicians. I wish I could have done it sooner. And registration closes on September 7th, so you're not too late. So this is a very timely presentation. As respiratory virus season approaches, literally next week, I'm excited to learn about the new tools and strategies we have to effectively protect our communities against these viruses. So today's learning objectives include to explore previous vaccination rates and attitudes towards seasonal vaccines among diverse demographic groups and populations, summarize ACIP recommendations for vaccines against RSV, COVID-19, and influenza, determine the best vaccination approach using patient case studies, develop follow-up strategies to monitor patient responses to vaccinations, address recent challenges encountered in vaccine distribution, and employ strategies to effectively communicate the importance of vaccination with patients. Now it is my pleasure to introduce Dr. Dial Hewlett Jr. Dr. Hewlett is a trailblazer. He is currently the Medical Director of the Division of Disease Control, Chief of the Tuberculosis Services at the Westchester Department of Health. Dr. Hewlett received his MD from the University of Wisconsin in Madison and is both certified in internal medicine and in infectious diseases. He completed an internal medicine internship and residency at Harlem Hospital Center, Columbia University College of Physicians and Surgeons in New York City. He also served an additional year as chief medical resident prior to beginning training in a 2-year clinical and research fellowship in infectious diseases at Montefiore and Albert Einstein affiliated hospitals in the Bronx, New York. Dr. Hewlett has held several roles over his career. He has served as the chief of the infectious disease division at Lincoln Medical and Mental Health Center in Bronx, New York, and associate professor of clinical medicine for 9 years prior to joining the pharmaceutical industry in 1996. During that time, and until 2014, he served as an infectious disease consultant at Lawrence Hospital, Bronxville, New York. Dr. Hewlett is a fellow of the American College of Physicians, the Infectious Diseases Society of America, and the New York Academy of Medicine. He currently serves as a consultant in infectious diseases and chair of the infection control at Calvary Hospital in the Bronx. He's also an adjunct associate professor of immunology and microbiology at New York Medical College in Valhalla, New York. Dr. Hewlett, on to you.
Thank you very much, Dr. Anjan, and it's indeed a pleasure to be here, and I'm honored to have been invited by the IDSA Foundation to take part in this important presentation. These are my financial disclosures. I have served on advisory boards for Pfizer. Here's an outline of the lecture. We're going to talk quite a bit about respiratory syncytial virus. We will devote a lot of the time to this because this is one of the newer areas, an area where there has been a lot more information recently. We will then say a bit about SARS-CoV-2, which I'm sure most of you are very familiar with this. I'm going to go over the adult portion, and Dr. Rogo is going to be discussing the pediatric aspects. And then I'm going to end by briefly mentioning some things about influenza, specifically some of the ACIP recommendations regarding the vaccine. So respiratory syncytial virus, this virus was first isolated in 1955 in chimpanzees with a respiratory illness. And the following year, 1956, it was isolated from infants with severe respiratory illness. We now know that a condition known as bronchiolitis in the infant, which can be life-threatening, is caused by respiratory syncytial virus most often. And the disease burden of RSV is similar to what we see with non-pandemic influenza A in our elderly and high-risk adults. Now, as far as the microbiology and pathogenesis is concerned, this is a filamentous enveloped single-stranded RNA virus. It's transmitted through close contact. So like the flu, it can spread. It can spread via aerosolized droplets. And after a short period of replication in the epithelial lining of the nasopharynx and the upper respiratory tract, an RSV infection may spread to the smaller bronchioles and alveoli of the lower respiratory tract. One of the important things for us to understand about this is that the host immune responses to RSV infection lead to an increase in mucus and secretion production and inflammation. And this can lead to an actual narrowing of the airway, which results in bronchiolitis in young children, and it can also be associated with acute respiratory illness in older adults and also in those who have underlying chronic respiratory conditions. Now, let's think about the burden of disease associated with RSV, which I think is a justification for paying a lot of attention to this as we go into the respiratory season, and particularly among adults 65 years of age and older here in the United States. It was associated with, and this is CDC data from 2022, about 14,000 deaths during that period of time. 177,000 hospitalizations, and 2.2 million cases of symptomatic illness. Next slide, please. Now, from a publication that came out in 2015 by Dr. Seema Jain and colleagues, which was published in the New England Journal of Medicine, they looked at data from 2 hospitals in Chicago and 2 hospitals in Nashville. And this was data that was obtained between January 2010 and June of 2012. And they looked at data from approximately 2,488 of 3,634 eligible adults. And among these adults, 93% had evidence of pneumonia radiologically. The median age of the patients was 57 years. Now, as you might expect, those of you like myself who treat a lot of patients with pneumonia, no pathogen was detected in about 62%. And this, of course, was done before we had a lot of the technology that we now have. Now, the pathogen detection among U.S. adults with community-acquired pneumonia that was requiring hospitalizations during that period of time, RSV was detected in 3% of those adults who were hospitalized with pneumonia. And it's likely that the rate was probably higher. And RSV was the 5th most commonly detected pathogen in this cohort. Next slide. Now, if we look on the outpatient side, the publication by Bologna and colleagues gives us some additional information. They noted that there was actually a substantial burden of medically attended outpatient visits for RSV in their cohort of older adults. Now, they were doing this study in Marshfield, Wisconsin, which is up in the central northern area of Wisconsin. And RSV was identified in 243 or 11% of 2,257 enrollments, 241 of the 1,832 individuals, including 121 with RSV type A and 122 with RSV type B. So RSV was detected in 11% of outpatients with acute respiratory illness. And of these individuals who had RSV, 19% had a serious outcome. The rates of RSV were nearly 2 times higher in patients who had chronic cardiopulmonary disease when compared with others. Next slide, please. Now, another important area for those of us who treat the adult population has to do with individuals who are in congregate facilities, such as long-term care facilities. And among individuals who are residents in these facilities, RSV was a frequent cause of symptomatic illness. There was a very high attack rate, as you can see here, more than 13.5% over 1 month. And this was work that was done by Dr. Bosco and his colleagues who were at Brown University. Next slide, please. Now, one of the other things that's very interesting that was pointed out in this study by Dr. Widmer and colleagues who were doing this work in the Nashville area, they found that there were similar rates of RSV and influenza in terms of hospitalizations in older individuals, if we look at hospitalizations due to respiratory causes. And in adults who were 65 years and older hospitalized with acute respiratory illness over 3 seasons, of 1,042 eligible patients, 508 consented to testing, and RSV was detected in 31 participants, or about 6.1%. Influenza was detected in 33, 6.5% of the patients. Similar clinical severity was seen when they compared the influenza versus RSV. The next slide, please. And this slide actually points out, just to summarize, and this is CDC data, that when we look at individuals who are hospitalized with RSV, cardiovascular disease was present in this analysis in about 57%, chronic lung disease 50%, and diabetes 34%. So it's important to think about this. And of course, in some of the individuals who were part of this cohort, they had more than one underlying condition. Next slide, please. And immunocompromised individuals are an extremely high risk for the development of severe disease. The greatest risk is in those individuals who are lung transplant recipients. However, there are similar rates of severity among those who have been the recipients of stem cell transplants. The incidence of symptomatic illness among this population is about 12% over this 2-year period of time of observation, and 16% during a single season for the lung transplant recipients. Severe outcomes were also noted in this analysis, and the mortality rate was as high as 26% among the stem cell transplant recipients. Next. And unfortunately, when we look at respiratory illness, we saw this with COVID, we see this persisting with influenza. RSV is no different. There are racial and ethnic disparities. Older adults who are Black, Latino, Latina, and Native Americans are more likely to be hospitalized with RSV at a younger age. And it's important for us to keep this in mind as we start to talk to people, to talk to our patients about vaccinations. Next slide, please. Now, the clinical manifestations of RSV infection, unfortunately, are not unique. And it's impossible to distinguish these individuals from individuals who have infections with other viral pathogens, including influenza and SARS-CoV-2. Next slide, please. Now let's talk a little bit about treatment and prevention. The next slide, please. Treatment, there's not a lot for us to really say. There's been a lot of talk and a lot of interest in ribavirin. And there's really, unfortunately, we don't have an FDA-approved agent to use for the treatment of RSV. There is some anecdotal information about the use of aerosolized ribavirin. And just to share with you my one experience in doing this, we actually had a young woman who had just delivered, and she developed respiratory symptoms during labor, and postpartum, she went into respiratory failure very rapidly and had to be intubated. And it was one of the most frightening things that I have experienced during my work as an infectious disease physician. And in discussing this with the pulmonologist, we actually were able to make a diagnosis of RSV rather quickly, fortunately. And we talked about using aerosolized ribavirin. And we actually did obtain the product from the manufacturer, and we administered it to the patient. And the patient actually improved rather rapidly. And so it's hard to say whether it was due to this therapy or whether the patient would have gotten better on her own since she was otherwise healthy. But that is my one anecdotal contribution here. Next slide. Now, the vaccines for RSV, there are 3 RSV vaccines that are licensed by the US FDA for use in adults ages 60 and older. There's the GSK product known as Arexvy, the Moderna's product, which was just recently approved and was and the recommendations were given in June of this year, the Resvia, and the Pfizer product Abrysvo. Next slide, please. So as far as the recommendations, in June of 2023, the ACIP recommended that adults age 60 and older may receive a single dose of RSV vaccine, and this was using shared clinical decision-making. A year later, June of this year, ACIP voted to actually bolster this recommendation, and they voted to update these recommendations as follows. All adults age 75 years or older and adults age 60 to 74 who are at increased risk for severe RSV disease should receive a single dose of RSV vaccine. Now, what were the implications for public health practice? These updated recommendations are intended to maximize RSV vaccination coverage among persons most likely to benefit. And there's going to be investigation, obviously, post-licensure to monitor to see what happens as far as these recommendations are concerned and if they need to be revisited. The next slide, please. And these are the recommendations that we just mentioned. So definitely recommended for individuals age 75 and older, and definitely recommended for individuals 60 to 74 who have underlying chronic conditions that we mentioned, as well as for those who reside in chronic care congregate facilities such as nursing homes. Next slide, please. And how long does this protection last? I won't go into all the details on this slide, but in general, it's believed that 1 dose of the RSV vaccine is going to last for 2 respiratory seasons, but data is still being gathered to give us more information as we move forward. The next slide, please. And adverse reactions that have been associated with the RSV vaccine are those that you would expect, such as pain at the injection site with redness and swelling. And there may be some associated fatigue, fever, and headache and other things that we saw similar to the COVID vaccines as the immunogenicity is kicking in. And these are usually mild. Now, one adverse event that is being studied actively is Guillain-Barré syndrome. A small number of participants in clinical trials developed this condition, and it was not completely clear that this was specifically related to any specific product, and so there's a lot more information that we still have to get on this adverse event. Next slide, please. Now, as far as COVID vaccines are concerned, we'll shift gears. FDA has approved and authorized the 2024 to 2025 Moderna and Pfizer-BioNTech COVID-19 vaccines. The 2023 to 2024 Novavax COVID vaccine remains authorized, but it's no longer available in the United States as all of the doses have now expired. Accordingly, at this time, CDC recommends for use of Novavax COVID-19 vaccine have been removed from the interim clinical considerations. As far as the two products that are available, the Moderna and the Pfizer BioNTech product, there is no preferential recommendation for the use of any one COVID-19 vaccine over another. And here at our health department, we really didn't have control over which product we were going to be using. It was determined by the state. And we more or less inform patients that whichever one you can get into your arm as soon as possible to take that product. The next slide. Now, as far as the recommendations are concerned, for people who are not moderately or severely immunocompromised, the initial vaccination for individuals 5 years of age and older would be 1 dose of either the Moderna or 1 dose of the Pfizer BioNTech product, whichever is available. Next slide. And as far as for individuals who have received previous doses of a COVID-19 vaccine, age 5 years of age and older, it would again be 1 dose of either the Moderna or of the Pfizer BioNTech product. Now, as far as additional doses, an additional dose of the 2024 to 2025 COVID-19 vaccine for people ages 65 and older who are not moderately or severely immunocompromised is not currently recommended. We go to the next slide, and this is the most recent recommendations, which were just from a few days ago. For people who are moderately or severely immunocompromised, we're talking about the initial vaccination, and Dr. Rogo will go into this in more detail, ages 6 months and older, 3 doses of either the Moderna or 3 doses of the Pfizer BioNTech product are recommended. If they've received previous doses of a COVID-19 vaccine, the recommended mRNA vaccine and the number of 2024 and 2025 doses are based on age and vaccination history. As far as additional doses, for people who are moderately or severely immunocompromised, ages 6 months and older, may receive 1 or more age-appropriate doses of this new product. Next slide. Now, as far as treatment is concerned, I'll just briefly mention the nirmatrelvir-ritonavir product is indicated for adults and children 12 years of age and older. It's an oral product. It should be started as soon as possible, but must be started within 5 days of the start of symptoms. And it's taken at home by mouth, so this is primarily an outpatient therapy. We think that for individuals who are ill enough to require inpatient therapy, the remdesivir product is something that has been used. This is an intravenous infusion, and it must be given in a health facility on 3 consecutive days. It's indicated for adults and children. Again, like the nirmatrelvir product, it should be started as soon as possible within 7 days of symptom onset. The molnupiravir product is also an option for adults. And again, it should start as soon as possible, and it's an oral product. Next slide. Now, just to finish up, we'll say a bit about influenza. And we cannot trivialize influenza. That last slide that I just showed you was from the pandemic in 1918. And it is still a major cause of hospitalization and, unfortunately, of death. So as far as the influenza vaccines are concerned, everyone 6 months of age and older in the United States, with rare exception, should get an influenza vaccine every season. CDC's Advisory Committee on Immunization Practices has made this universal recommendation since 2010-2011 influenza season. Vaccination to prevent influenza and its potentially serious complications is particularly important for people who are at high risk for developing serious influenza complications, and this includes our pregnant mothers. Next slide. And so for people younger than 65 years, CDC does not preferentially recommend any licensed age-appropriate influenza flu vaccine over another. Now, for people 65 years and older, there are 3 flu vaccines that are preferentially recommended over standard dose unadjuvanted flu vaccines. And this is from the ACIP, and usually they do not have preferences, but in this case, they did have these preferences, and the recommendations are the use of one of these three products: the Fluzone high-dose quadrivalent vaccine, the Flu Block quadrivalent recombinant flu vaccine, or the Fluad quadrivalent adjunct flu vaccine. Next slide. Inactivated, and this is just a question that comes up very often. Concurrent administration here at our health department, when we have the person in front of us, we try to give the vaccines concurrently because we know that they may not come back. And so inactivated and recombinant influenza vaccines may be administered concurrently or sequentially with other live or inactivated vaccines. Injectable vaccines given simultaneously should be administered at separate anatomic sites. And the current guidance for the use of the COVID-19 vaccine states that these vaccines may be administered with influenza vaccines. And you should, of course, consult with some of the literature on the CDC website. The next slide. And as far as treatment is concerned, it has been shown that treatment is beneficial if we suspect influenza, and there are 4 FDA-approved antiviral drugs that are recommended by the CDC to treat influenza this season. The oseltamivir is a generic, there's a generic version, and the trade name is Tamiflu, and there are also 2 other products which can be used as well, and this is from the CDC earlier this year. Next slide, please. And I think that an ounce of prevention is worth a pound of cure, and the flu vaccine can take the flu from wild to mild. So with that, I will end my presentation, and I will turn it back over to Dr. Anjman. Thank you.
Thank you for that insightful presentation, Dr. Hewlett. As a reminder to our audience, please use the Q&A button to ask any questions at any point in the presentation. Now on to our second speaker. It is my pleasure to introduce to you Dr. Tanya Rogo. Dr. Rogo is an associate professor of pediatrics at the Warren Alpert Medical School of Brown University. She's the program director for the Pediatric Infectious Diseases Fellowship Program, global health educator in the Department of Pediatrics, and the medical director of antimicrobial stewardship at Hasbro Children's Hospital in Providence, Rhode Island. In addition, she co-directs the Global Health Scholarly Concentration for Brown medical students. She completed her undergraduate education at the University of North Carolina at Chapel Hill, and then received her medical degree and Masters of Public Health and Tropical Medicine from Tulane University. She went on to complete residency in general pediatrics at the Inova Fairfax Hospital for Children in Falls Church, Virginia, followed by fellowship in pediatric infectious diseases at Brown University Hospital Children's Hospital. Dr. Rogo is the vice chair of the Pediatric Infectious Diseases Society Inclusion, Diversity, Access, and Equity Committee. She also serves on the National Medical Association's Task Force on Therapeutics and Vaccines, as well as the Council for International Affairs. Dr. Rogo, on to you.
Good afternoon, everyone. So it's my pleasure to follow Dr. Hewlett and talk about the pediatric aspects of what we need to think about for the next season. Here are my disclosures. I'm just a site PI for some COVID-19 clinical trials. Next slide. So we're going to start with RSV. Next slide. So in terms of RSV prevention in infants and children, there are 2 options for RSV prevention during their first RSV season. The first option is to vaccinate the mother, for which we have 1 vaccine that has been approved, which is the Pfizer RSV vaccine. And then the second option is a new monoclonal antibody, new as of last year, called nirsevimab, for which infants are eligible if they're less than 8 months old. If a child is age 8 to 19 months and has risk factors for severe RSV disease and are entering their second RSV season, they are also recommended to receive 1 dose of nirsevimab. And so the ACIP recommends that all infants be protected by either maternal RSV vaccination or nirsevimab for this upcoming RSV season. Next slide. So when should we vaccinate or provide protection? So some of this has become challenging because you may be aware that over the last 2 years, we've had interseasonal, both with RSV and influenza, some interseasonal spread. Generally, September to January is a traditional RSV season. And so for women who are pregnant, the recommendation is that they receive the maternal RSV vaccine at 32 to 36 weeks of gestation during the RSV season. And for the infant, if they're under 8 months of age, they should get immunized right when the season is starting, depending on where you are in the United States. Or if the child is born between October to March, that you immunize them within 1 week of birth. And recognizing, of course, the seasonality differs around most of the United States, and so you should follow your local guidance on timing of administration. Next slide. Now, a question that's going to come up this year is what to do if a woman has previously been vaccinated with the RSV vaccine in her previous pregnancy. So for example, if she was pregnant last season and received a vaccine last season, and then she's pregnant again this season and will have a baby this season. So the current recommendation is if they've received it in a previous pregnancy, they do not need to receive additional doses. And the babies who are born to women who've been previously vaccinated in a previous pregnancy, but were not vaccinated during this pregnancy, that infant should receive nirsevimab. And then we will expect in the future that probably as more data comes out that this recommendation may change. But as of this season, if a woman received RSV vaccine in a prior pregnancy, she should not receive it again this season. Next slide. And then the next common question is what to do if there is an error with administration of the RSV vaccine. As Dr. Hewlett had mentioned, we now have 3 RSV vaccine products on the market. We should all be aware that none of the RSV vaccines are approved for use in children, and that the Pfizer product is the only RSV vaccine approved for pregnant people. And there were reports in the last season of the wrong vaccine being given in outpatient and settings and in the pharmacy. Most had no adverse events reported. And when reported in VAERS, most were classified as non-serious. Next slide. So in terms of the recommendation of what to do if there's been an error in administration, is if an infant by mistake received an RSV vaccine, then that infant should receive nirsevimab. If the mother received the wrong RSV product, meaning that she received something else other than Pfizer, then the infant should receive nirsevimab during the RSV season. Next slide. In terms of coverage, unfortunately, and maybe this is to be expected with new products rolling out right when the season was coming out, and there were also issues with availability. Only 17.8% of pregnant persons who were eligible were vaccinated against RSV. And you see here in red that Asian pregnant persons had the highest rate of vaccination at nearly 25%. And Black pregnant persons had the lowest rate of vaccination at 10%. So an obvious health disparity there. Next slide. And in terms of the proportion of infants who are eligible for protection who actually received it, it's estimated that 51.2% of infants were protected by either nirsevimab or maternal RSV vaccination in the last RSV season. And this is a combination of 43% of eligible infants receiving nirsevimab and the 17.8% of eligible birthing parents receiving RSV vaccine. Next slide. So what do we know about RSV vaccine safety in the mother? So from the ACIP presentation, they report that in clinical trials among pregnant persons at 24 to 36 weeks gestation, what was most noted is that there were more preterm births noted among those who received the Pfizer RSV vaccine compared to placebo. They started post-licensure safety surveillance during last season. And they report that the patterns of reported local and systemic symptoms in VSafe and VAERS were consistent with pre-licensure safety profile. In VAERS, the most frequent adverse events reported were pregnancy-specific, such as preterm delivery. And the incidence of preterm birth was reported at 4.1% among pregnant persons who received the Pfizer RSV vaccine. And they reported that this is within the expected range of the incidence of preterm birth at 32 to 36 weeks gestation, which is 3.1 to 6.1% prior to the introduction of the vaccine. Next slide. And looking at a cohort of infants born to the birthing parent who received Pfizer RSV vaccine. They had 75 infants here, of which 51% were born premature. There was one reported infant death, and they state here that this was a 35th-week infant with a anoxic brain injury and neonatal death after emergency C-section. And 24 of these infants had a NICU admission. Next slide. And then looking at nirsevimab safety in infants, it was noted in post-marketing surveillance that there were reports of serious hypersensitivity reactions, and these included urticaria, dyspnea, cyanosis, and hypotonia. And so this has been added to the product labeling as of February of 2024. Next slide. And looking at nirsevimab effectiveness. And so this is an MMWR report from the New Vaccine Surveillance Network. Next slide. And this looked at first season nirsevimab product effectiveness. Again, medically attended RSV, acute respiratory infection, and also RSV associated hospitalization. And what you see here that up here among infants who received nirsevimab, those 89% effectiveness against medically attended RSV illness. And for those who against hospitalization, it was 91% effective. Next slide. And just to make you aware that the AAP has resources available, including this visual guide to help with decision-making about whether or not the infant is eligible for nirsevimab, and as well as which dose of nirsevimab, because there's a 50 milligram syringe and a 100 milligram syringe. And so this is available on the American Academy of Pediatrics website. Next slide. And then to just also highlight some additional AAP recommendations about nirsevimab. And so cases where nirsevimab should be considered for infants who've been born to a vaccinated pregnant woman, because if you recall, the general recommendation is that the baby either receives nirsevimab or the mother is vaccinated during pregnancy. But if it is thought that the mother may not have mounted a response to the vaccine, then this babies could be considered for nirsevimab. So these include infants born to pregnant people who may have immune compromising conditions or who have conditions associated with reduced transplacental antibody transfer. Infants who have experienced loss of transplacentally acquired antibodies, such as those who undergo cardiopulmonary bypass or ECMO, and infants who have substantially increased risk for severe RSV disease, such as hemodynamically significant congenital heart disease or NICU admission. Next slide. In addition, infants and children aged 8 through 19 years of age who are at an increased risk for severe RSV disease and who are entering their second RSV season, including those who would otherwise be recommended to receive palivizumab or Synagist, regardless of the RSV vaccination of the pregnant parent. These children should be considered for nirsevimab. So these are infants and children with chronic lung disease requiring medical support at any time during the previous 6 months before the RSV season, children who are severely immune compromised, children with cystic fibrosis, with severe lung disease, or weight for length that is less than 10 percentile, and American Indian and Alaska Native children. Next slide. And in terms of palivizumab versus nirsevimab, if nirsevimab is not available, high-risk infants who are recommended to receive palivizumab in the first or second year of life should go ahead and receive palivizumab. High-risk infants whose pregnant parents received an RSV vaccine at least 14 days prior to delivery do not require palivizumab or nirsevimab. And that if a child receives nirsevimab, then you should not give them palivizumab later that season, because the length of time that nirsevimab is supposed to be protective is for at least 5 months. Next slide. Now, what if the infant has already started the palivizumab 5-dose series? So if they received it initially, but did not complete the 5 doses, then they should receive 1 dose of nirsevimab if that is available, and then you don't give any more palivizumab. There's no minimum interval recommended between the last dose of palivizumab and the dose of nirsevimab. And because the protection of palivizumab wanes after 30 days, nirsevimab should be administered no later than 30 days after the last palivizumab dose, whenever possible. Next slide. And then what to do if the infant received palivizumab last season and is still eligible for RSV prophylaxis in their second RSV season. So if nirsevimab is available, you can go ahead and give that child nirsevimab. If nirsevimab is not available, then they should receive palivizumab as previously recommended. Next slide. Right, so let's move on to COVID-19. So last year, as you I'm sure all aware, we had the updated vaccine made available. And for children, Moderna and Pfizer was recommended for all infants 6 months and older, and Novavax for those who are age 12 and older. And then for those who are age 5 and older, they only need to get 1 dose of the 2023 to 24 COVID-19 vaccine. Next slide. So what did we see this past winter season? So you'll see here in pink is children aged 6 months of age and under. Blue is 6 months to 4 years. Green is 5 to 11 years, and yellow is 12 to 17 years. And we see that hospitalizations are highest in children who are under the age of 6 months of age, which really emphasizes the fact that we need to continue to counsel our pregnant women to get vaccinated because babies are not eligible for COVID-19 vaccine until 6 months of age. And so this is where transferred antibodies from the mother can come into play in terms of protection. Next slide. What we also see additionally in terms of underlying medical conditions is that 50% of infants and children under the age of 7 who are 17 and under do not have underlying medical conditions. And in fact, the younger the child, the more likely that they are hospitalized with COVID-19 without an underlying risk factor. So for those who are under 6 months of age, 75% had no underlying conditions. Those who are 6 months to 2 years of age had 58% with no underlying conditions, with 36% for those who were older than age 2. Next slide. And our data continues to support that COVID-19 vaccination is protective against hospitalization. So only 5% of children who were vaccinated who received the 2023-2024 COVID-19 vaccine dose were hospitalized. And so you see here in the table, in green are the children who received the 2023 to 24 vaccine, right? So only 6% in those age 6 to 4 months were hospitalized, 3% age 5 to 11 years, and 3% to 12 to 17 years. And COVID-19 continues to be a leading cause of death. And so as part of our counseling for our patients is that COVID-19 vaccination is protective against hospitalization. Next slide. And so fresh off the press, was that we have a new vaccine coming up, as Dr. Hewlett mentioned, and it's recommended for those who are 6 months of age and older. Next slide. And just 6 days ago, the CDC updated their dosing recommendations with the new vaccine. So for initial vaccination for infants who are aged 6 months to children aged 4 years of age, if they've not previously been vaccinated, they should get either 2 doses of Moderna or 3 doses of the Pfizer vaccine. If they're age 5 and older and they're not previously vaccinated against COVID-19, then they just need 1 dose of either Moderna or Pfizer. If they've previously been vaccinated, if they're age 6 months to 4 years, depending on how many doses they've received, they will get 1 to 2 doses of this year's vaccine to complete their initial series. If they're 5 years and older, they should just get 1 dose of either Moderna or Pfizer. Next slide. If they're immune compromised, if they are being initially vaccinated at 6 months and older, they should get 3 doses of Moderna, right? So this is different from those who are not immune compromised, only need 2 doses. They get 3 doses of Moderna or 3 doses of Pfizer. If they've received a previous COVID-19 dose, then you give them the number of doses recommended based on age and vaccination history. In addition, for those who are moderately or severely immune compromised, they may receive 1 or more additional doses of the 2024-25 vaccine. Next slide. And then I'm going to end with influenza. Next slide. So what did we see last season? So for children and adolescents, we saw that the influenza vaccine was 59 to 67% effective in preventing outpatient medical visits and 52 to 61% effective in preventing hospitalization. However, only half, so only 54% of children and adolescents were vaccinated against influenza last season. And we saw disparities in who was vaccinated, with the coverage being lowest for Black children at 49%, compared to 51% of white children and 60% of Hispanic children. And that children living in rural areas also have significantly lower vaccination rates compared to those in urban and suburban areas. We saw a bump in pediatric deaths, rising to 188, which is the highest death toll we've seen among children and adolescents since the 2019 to 2020 season, when we saw 199 deaths. Next slide. So the recommendation is that ACIP affirms the recommendation that everyone 6 months and older should receive an annual vaccine, as long as they do not have any contraindications. Next slide. And in terms of the number of doses, this has not changed. So if they're aged 6 months to 8 years of age and they've never been vaccinated before with the flu vaccine, then they should receive 2 doses that are spaced at least 4 weeks apart. If the child is 8 years old and then turns 9 between dose 1 and 2, they should finish with the 2nd dose. And compared to COVID-19 vaccination, where a child should ideally receive the entire series from the same brand, that does not apply for influenza. So in influenza, if they're supposed to receive 2 doses within a given season, those doses don't need to be from the same brand. And then all other children should receive 1 vaccine as part of their annual vaccinations. Also, there's emphasis on co-administration, including with nirsevimab. Next slide. And so what can we do to increase childhood influenza vaccination? So one is just the language that we use when we're recommending an influenza vaccine is that it should be presumptive, right? So instead of saying, can I give you the influenza vaccine? Some language that's encouraged is to say your child is due for influenza, Tdap, or any other vaccine that they're due for, right? So to bundle the recommendation of influenza vaccine with other needed vaccines to make sure that our staff members have the same consistent messaging. We should review influenza vaccine status at all visits. I'm an HIV provider, and I look at vaccination status at all visits with my patients. And that we should offer vaccines at all visit types. Outside of well-child visits, we can give them at acute care visits. At my hospital, we also offer it to patients when they're being discharged from the hospital. Next slide. And that brings us to the end. And so I will segue back to Dr. Anjan.
Thank you, Dr. Ogo, for that excellent overview. Now, if you and Dr. Hewlett can please unmute and turn on your video for the Q&A portion of this webinar. Okay, so I think the first one that Dr. Hewlett can take live is a question on, is COVID vaccine considered annual despite that its efficacy wanes after 4 months? Would it be better to be vaccinated closer to peak season around the holidays, say end of December or early January?
That's an excellent question. And although it is considered annual, I think that at least during the pandemic, we knew that there were changes that were made. Unfortunately, unlike influenza, we can't really predict when a surge in COVID is going to occur. And so I think that it's for that reason that it's recommended that it's given during this same season when influenza vaccine is given. And I think the other practical aspect of this is if people are getting their influenza vaccines, they should ideally receive it during this period that we are now entering, because we know that influenza may actually start in late October or early November. And so we want to make sure that we have adequate protection. So to answer your question, I think it is ideally something that we should give annually, but we can't predict when the surges are going to happen with COVID.
Thank you, Dr. Hewlett. The next one for Dr. Ogo to answer live. If a pediatric patient has significant congenital cardiac anomaly and over 8 months old and has not received a dose of nirsevimab for the first season, will this patient qualify for nirsevimab?
Yes, so they will. For babies who are older than 8 months of age up until 19 months of age, if they have risk factors for severe RSV, which you will find listed on the AAP website or the CDC website. And so these are the same indications as for those who qualify for Synagis or palivizumab. They will qualify for nirsevimab. So they can get either nirsevimab or palivizumab, whichever one is available.
Got it. Thank you. Another question for you while we have you here. Were there more preterm births and vaccinated mothers because these were high-risk mothers to begin with and had risk of preterm birth irrespective of the vaccine? I'm assuming this is to do with the RSV vaccine.
Yes. So this is one of the, I guess, the data that came out both in the pre-licensing studies and that they've also seen in post-licensure is premature birth. It's unclear whether or not it's actually the vaccine that's causing this because the otherwise expected incidence for preterm birth is around the same, right? So they report about 4% preterm birth. The range of preterm birth is about 3 to 6%. So as of right now, I would say that it's unclear that that's actually the RSV is the RSV vaccine is the reason.
Thank you, Dr. Ogo. I guess this question is for both Dr. Hewlett and Dr. Ogo. How can we best encourage staff to speak with patients and encourage them to get vaccinated? We are dealing with a lot of hesitancy.
Well, I can tell you what our experience is here at the Department of Health, and I think the most important thing that we have to do is not to follow our impulse, which is to start to be upset with the individual. I think that we have to listen to the individual and we have to ask them to explain why they have concerns about the vaccines and try then to explain to them why it's to their advantage and to their benefit to be vaccinated. And also the tactic which we have used sometimes successfully is saying that getting vaccinated is not just about you. these are respiratory illnesses. And so if, for example, with the flu, if you get the flu, then other people in your household and in your family and friends can become infected, and it can actually have dire consequences. So these are some of the things that we try to do.
I also like to add that I think it's also important for us to address hesitancy within our own selves, our medical staff, because if the staff themselves are hesitant, then they're less likely to counsel patients, right? And so to also remember that to be doing education with our staff.
Agree.
Agree. Thank you, Dr. Ogo and Dr. Hewlett. I think another thing is to bring it up at every patient visit, because I feel like every time they hear it from you, they're reassured. They may have more questions, or, you know, give them some time to think about it and come back. Especially with transplant patients, I try the multiple physician contact approach. So it's not just me. They hear it from, you know, nephrologists. They hear it from other people in their care team, and so they're more likely to get vaccines.
Yeah, I agree. And sometimes I see my patients more than their general pediatrician. For example, in my HIV clinic, when I'm seeing patients every 3 months versus they're going to the pediatrician maybe just once a year for their annual, which is why it's important for us at each visit to assess their vaccination record. And if they have things missing, we take that opportunity to offer the vaccine.
Perfect. There is a follow-up question. I believe congenital cardiac disease is not listed as an indication for 8 to 19 months for nirsevimab. For palivizumab, it is listed for first season. Just to clarify then, if a patient is between 8 to 19 months with congenital cardiac issues, has been vaccinated during the first season, but cardiac condition remains significant, will this patient qualify to receive a second dose during the second season?
So thank you for that correction. So if it's not listed, I can't make a recommendation outside of what's recommended. So, right, which is why I say refer to what the AAP lists as indications. And so they've just updated their I believe they're up their recommendations. And I can take a look. I know chronic lung disease is one of the indications, but I thank you for that correction. I believe that congenital heart disease may not be for a second nirsevimab.
Thank you, Dr. Ogo. I think we have time for one last question. Is there any data or evidence that COVID mRNA will cover newer emerging strains of COVID?
I don't think that we have evidence about what's going to happen in the future. I think that the current product, and I would certainly defer to Dr. Rogo and yourself, the current product is based on the strains that we now have that are most prevalent. And all of them, I think, came originally from that Omicron strain.
That is correct. And we may never have vaccines that are 100%, but they will protect you and keep you out of the hospital, which is what we need.
Yes.
Okay. I think we are just about at time. So if there are any questions we have missed, we will do our best to get to you via email or answer them in the chat. Thank you again for your excellent presentations, Dr. Rogo and Dr. Hewlett.
You're welcome.
I will pass it back to you, Ty, to close us out.
I do want to thank all of you for your time today, and also a big thank you for Drs. Anjan, Hewlett, and Rogo. This has been great. Just a few quick reminders as we close out. ID Week is 7 short weeks away, and that's October 16th to the 19th. We hope to see you in Los Angeles. Next slide. We also invite you to check out idsafoundation.org and look for the next 2 installments of our John G. Bartlett Education Series. And you'll get all the information there and updates as we move through the rest of the year. We have some exciting topics. And finally, if you are not yet a member of IDSA, please also look at the idsa.org, idsociety.org, a website to get more information about how to become a member. And I think we finished actually right on time. Thank you so much to all of you. Have a great afternoon.